Okay, great. Try and step into the camera view. So welcome to this hybrid colloquium, those in person, those on Zoom. It's my pleasure to introduce our speaker today, Stephen Kissler. He's an infectious disease epidemiologist at the Harvard T.H. School of Public Health. He earned his PhD in applied mathematics at the University of Cambridge as a Gates Scholar, where he studied the transmission of the 2009 H1N1 influenza pandemic. Now at Harvard, Stephen is focused on identifying drivers of antibiotic resistance, and then more recently on SARS-CoV-2 pandemic response. In addition to his research, he's consulted with partners in health, has provided comments for numerous media outlets during the COVID-19 pandemic. And outside of work, Stephen is an avid road cyclist, used to be a player in various symphonies of the violin, and is now a player in the Brookline Symphony in Boston. Also of note, Stephen has a brother who is an internal medicine doctor, and the two of them together have an interesting podcast, Infectious Disease Epidemiology and on the pandemic. So if you don't get enough in today's colloquium, be sure to check that out. You can find it on Stephen's website, as I've discovered. With that, please thank Stephen and welcome.
Thank you so much. Yeah, thanks, Dan, and for all of you for giving me such a warm welcome here. It's wonderful to be here and wonderful to also see some familiar faces. Yeah, so today I'd like to give an overview of some of the research that I've done. The main focus is going to be work from my PhD and postdoc, but I'd also like to talk a little bit about some of the work that I hope to do once I start as a faculty member. All of which is going to be oriented around this idea of building computational tools for pandemic readiness. Let's get this working. So yeah, so as Dan mentioned, I've gotten to study in some remarkably beautiful places. And each sort of stage in this process has been aimed at trying to take my interest in infectious diseases more and more towards implementation. So the applied math was really trying to get the nuts and bolts of mechanistic modeling of infectious diseases. During my PhD, I really focused specifically on 2009 pandemic flu. And then I've been thinking a lot more about, from the public health perspective, how we deal with infectious diseases. So my hope with this next career stage is to take one step even closer to implementation. And that's one of the reasons why I'm so interested in computer science. I think a lot of the things that we've done during the pandemic and a lot of the opportunities that we have to do with building calculators, building models that can be used by policymakers, finding different ways to optimize scarce resources in a way that is dynamic and adaptive and mindful of the ever-shifting dynamics of infectious disease outbreaks. So that's why I'm here, and I'm looking forward to continuing this discussion with all of you. Before diving into sort of the narrative chronological outline of the research that I've been working on, I wanted to give a quick overview on 2 slides of the way that I see the research that I do. So I'm really interested in infectious disease ecology, thinking of the ways that infectious diseases spread across scales. So thinking about the pathogen level, the human behavior level, and the societal level, and all of the different complex ways that they can interact with one another. And I think that that's an interesting problem, but the thing that really gives my research direction is medical technology. And I think we're really now in an interesting time for medical technology after the pandemic, where we have new medications available, we have new vaccine platforms available, we have new testing paradigms available, and there's been a huge explosion in sequencing capacity. So there are big questions now. How do we optimize the use of these technologies? And how do we do so in a way that is mindful of infectious disease ecology so that we don't get unanticipated outcomes by intervening at one scale and then having the exact opposite effects happen at another scale? So to make the technology speak with the ecology well, we really need these computational tools, and that's what allows us to generate effective interventions. I also want to address sort of the type of modeling that I tend to do. And I see sort of 2 main areas of infectious disease epidemiology that's been happening lately. The first is rooted in machine learning, and frequently that yields epidemic forecasts. Oftentimes these are looking a couple of weeks ahead, trying to understand how many patients are going to be admitted to the hospital, how many deaths are going to occur. And we've gotten much better at making these kinds of forecasts. But this is really not the area that I spend most of my time thinking about. Rather than thinking about, given the scenario that we're in, what will happen in a couple of weeks, what I'm really interested in asking are these sort of complex if-then questions, which we really need mechanistic models to answer. So on the bottom left here is a model that we built in the context of the COVID-19 pandemic, which I'll talk about in a little while. But for the purposes of this slide, really all I want to highlight is that I'm not going to be talking about really forecasting so much, which is really one important area of infectious disease dynamics, but rather building mechanistic models to get a deeper understanding of the spread of infectious diseases. Who are the key players in transmission? Who has the most severe disease outcomes, and what might happen if we intervene now in this way in a few months' time. So it's really sort of this scenario modeling, trying to ask questions of how should we intervene now to have much longer term, more durable impacts on the spread of disease. So to begin sort of the chronological walkthrough of some of the work that I've been involved in, and I wanted to start with this project, really one of the central projects of my PhD, but it really gave birth to a lot of what I did, what I've done since then. And it has to do with tracing the geographic spread of the 2009 H1N1 flu pandemic. There are a couple questions we were interested in here, including how do we prioritize surveillance early in an epidemic? Once an epidemic, like a pandemic, gets established, how is it going to spread? And which demographic groups are most vulnerable to disease? And to begin answering these questions, we fortunately had access to this really interesting data set. There were time series of influenza-like illness across 800 different cities in the United States. So influenza-like illnesses, it's collected when a person goes to seek care for infection. And we're not necessarily looking for specific diagnoses of flu, but instead, and including flu, but we're also looking for fever, sore throat, chills, anything that might be consistent with influenza-like symptoms. So not everything in these time series that I've depicted along the top will be flu, but you can imagine that a lot of the trend is driven by flu. And so we can extract some information from these time series to get a sense for how the flu spread. So one way to look at this, since we have a lot of geographic information, is to just map it, to look at a video of the spread in the United States over time. So each of these disks represents a city for which we have data, and I'm going to fire off this video in a moment, and the disks will turn darker as the influenza-like illness in that location increases. And there were a couple of surprises when we looked at this this data in this way. The first thing was that there's this remarkable sort of like ripple of spread coming out of the southeastern United States, which was not at all how I or many of my colleagues thought a pandemic flu strain would spread. We're highly connected. We have large cities that have air travel and trains that move between them. Never has our world been more connected. So you would expect, or I would expect, the epidemic to really take root in New York, Chicago, Los Angeles, spread outward from there, hop between cities, and then go to more rural areas. Which doesn't seem to be at all what was happening here. So to try to get a deeper understanding of what was happening here, we built a mathematical model, which is actually at heart relatively straightforward. We said that the force of infection, or the amount of transmission that's happening between city I and city J, is characterized by this term, just a constant multiplied by the population sizes of the cities and divided by some decaying function of the distance between them. So basically, larger cities are more attractive to each other. The farther apart you are, the less likely there is to be an interaction. And then there's some baseline probability, beta naught, of importing infection from somewhere far away. What this allows us to do is to both estimate the parameters of this model, so we can determine sort of what characterizes the spread of this epidemic. But then what you can do is you can flip the entire model backwards. You can take these arrows, turn them backward, and essentially get an ancestry model where you identify where the epidemic most likely spread from. And so when we do that, you can identify a couple of locations in the US that seem to be places where we had an initial epidemic establishment of the 2009 flu pandemic. And then when you do that, you can trace the epidemic forward again. And so we've colored sort of these basins of transmission according to where the epidemic was first introduced. And so some interesting things arise when we see that the places where we first saw really this establishment of infection don't seem to be major cities. And in fact, that the infection that was seeded in the southeastern United States really propagated forward and spread across a lot of the country. So what does this tell us? So we learned two main things. First, that a respiratory pandemic isn't necessarily going to surge in a large city first. So we really need to distribute surveillance widely if we want to make sure that we have early warning of a pandemic that's about to spread. And the second is that passive surveillance data like this, as long as we thoughtfully incorporate it into models, can also improve our understanding of the genetic diversity of an epidemic. So we can think about this a lot with the context of SARS-CoV-2, where we have the spread of variants, and those variants are sometimes very geographically isolated. With a model like this, you might be able to identify an introduction site of a different variant of SARS-CoV-2. And if you want to understand the genetic diversity of variants across the country, you could optimize your sequencing, basically the surveillance that you do to try to understand which variants are circulating where. And knowing where the spread came from, you can essentially use this as a Bayesian prior, essentially, for where you build your sequencing. So there are a lot of different applications for this, but those aren't the directions that we headed immediately next. One of the things that we were really interested in characterizing was this ripple-like spread. One of the things I want to highlight is this is the spread of the COVID-19 pandemic from the covidestim.org. And we actually see very similar patterns. We see, again, these sort of like ripples of transmission from North Dakota earlier on, and then from the southeastern United States later. So I don't think that these dynamics are necessarily specific to flu. I think that these might be much more general for respiratory infections. And so it would go a long way for us to better understand where they're coming from. So a couple of hypotheses. One is that spread could be mainly driven by children who travel shorter distances. Maybe that explains the more localized spread since they're not getting on airplanes as often. Maybe just overall movements are a lot more localized than we previously thought. Maybe we overestimated how much travel is happening on airplanes. And then this last one I think is interesting. There could be an element of super spreading in play here. So the idea behind super spreading is that most people who get infected aren't going to spread infection to other people. And so if you have essentially a spark of infection, somebody who's infected who travels to a new city, but if there's a lot of super spreading happening for this pathogen, chances are they aren't going to infect anybody. So in order to get an epidemic to really take off, you need a lot of introductions. And that can only happen when cities are really close together so that there's sort of a lot of infections feeding the fire. So we wanted to take a look at each of these hypotheses in kind. So this is moving on to one of the next projects I'd like to talk about, which is looking at the age structure of pandemic flu transmission. So thinking about which age groups drive the spread of the flu, and one of the applications for this might be when we're distributing vaccines, who should we vaccinate first? This part of the project was using the same data set, but in addition to having it across 800 different cities, we had 12 different age groups available. And so essentially what the problem reduced to in our minds was, how can we fill out this matrix? So if we think about along the top, the 12 different age groups, and along the right, or along the left, the same age groups, how can we fill in this matrix, essentially a heat map of how much transmission is coming from one age group along the top to the age group along the left? Well, it turns out that's a bit of a complex problem because there are a number of different ways that you can do this. One of the natural ways that you might think about doing this is by building a mechanistic model, something that characterizes the spread of disease between age groups. But since there are so many interactions here, there are just far too many parameters to estimate reliably. So we can take a step back, and instead of looking at these time series as strictly quantitative objects, we can sort of look at the qualitative structure of these time series instead. So one of the things with influenza-like illnesses, we don't necessarily expect the absolute magnitude of illness to be comparable across locations, because there will be differences in physician-seeking behavior, differences in coding, different things that we need to account for, so that a certain number of cases in one place doesn't necessarily map to the same number of cases in another place. But we do expect increases and decreases to roughly map from one place to the next to mean similar things. So one thing we can do to try to understand these epidemiological relationships is to characterize these time series as Markov chains, but as symbolic Markov chains. So for this time series of children on the top and adults on the bottom, we can generate a very simple Markov chain that just consists of 4 different states where you can either be increasing, turning around, decreasing, or flipping around the other direction and coming back up. And so you can essentially think of these time series as an instance of some walk around this Markov chain. And so then using these time series, since we have a lot of them available, we can estimate the transition probabilities in this Markov chain. Well, how does that help us? Well, but for example, let's take a look at what's happening in the adult time series here. So they've been increasing and now they've just peaked. And if we train this to all of the adult time series that we have available, we might see that the probability of turning around for the adult time series, given that you've just been increasing, is about 5%. But then if we allow ourselves to peek at what's just happened in the child's time series, we see that they've just peaked just before the adult time series has. And so if we account for that information in the conditional probability, we can see the probability that the epidemic will peak, given that the adults have been increasing and that the children have just turned around, is suddenly a lot higher. And so if we measure this change in predictive accuracy across different age groups, then we can get a sense essentially of epidemiological driving. Basically, how do the dynamics in one group affect the dynamics in the other? And so if we measure this change in probability across age groups, we see that it looks like, according to these time series, it really is school-aged children who are driving a lot of the transmission. On the other hand, there's sort of this patch of gray in the bottom right, which suggests that maybe there's a separate set of epidemiological dynamics amongst the elderly, which again sort of aligns with what we saw during COVID-19, where there was a lot of transmission in elderly care homes, whereas younger adults, I think for COVID, probably the age structure was shifted a little bit more towards young adults versus school-aged kids. But this really matches up with a lot of what we understood about flu previously. So there are some limitations to this method. One of them is that if there are differences in the rate at which you seek care relative to the onset of infection, that can also bias this because there can be differences, different temporal shifts from one age group to the next. So there are definitely some limitations to be worked out with this, but nevertheless, this is sort of like a new tool that you can use to try to understand some of these relationships. Next, and this will be wrapping up the emphasis on pandemic flu, and then I'll transition into some of the COVID research we've done. Going back to this question about the ripples of transmission, one of the hypotheses was that maybe just overall movements are a lot more local than we thought. But it turns out until recently, we really didn't know an awful lot about how people move and interact. We've needed mobile sensing technologies to really get a sense for that, which have really only come around very recently. So we can ask some related questions. How does mobility vary by age and geography? How do interpersonal contacts vary across settings? How variable are these contacts across individuals? And the previous work in this area, there's been a lot, and it's taken place in a couple of different areas. So one is looking at really long distance movements using essentially pings from cell phone towers. And so this is a map of malaria in Kenya and looking at basically sources and sinks of human mobility and mapping that with the transmission of disease. There's another paradigm, which is using social contact surveys. So in the middle is this polymod study, is what it's called, which a lot of infectious disease modelers use to look at the interactions between age groups. So essentially, a survey was mailed out to a bunch of people in different countries across Europe. You were asked to write down who you've been in conversational contact with over the course of the previous week. And you end up with these matrices with this sort of tri-diagonal pattern where you see that people of similar age groups tend to interact with other people of their same age group. But then there are these off diagonals of parents essentially interacting with kids. And then at the finest scale, there are these remote sensing technology that are trying to get essentially interpersonal contact networks. So how do conversational contacts vary over time in very small specific communities? And there wasn't really much work that had been done to link up these different scales of transmission, but if we really want a robust pandemic infectious disease transmission model, we really want for a single population a good sense of how to translate between all of these different scales. So that's what we set out to do. This was in collaboration with the BBC. So we worked with the BBC, who did a lot of the outreach, and they were generating a documentary on pandemic preparedness in 2018, which was unbelievably prescient, we now know. And worked with a team of app developers. And then this was our group at the Department of Applied Math in Cambridge to develop this app. And it was essentially a citizen science study. There were two parts of the study, one of which was this national outbreak. But really what it was people would sign up and the app would track their movements within 1 kilometer resolution once per hour over the course of a day. And then at the end of the day, they would fill out one of those contact surveys. So for the first time, we would be able to link up the contact survey with the long distance movements. And then there was a second study, which we called the Hazelmere Outbreak, where people in the town of Hazelmere in the south of England basically let us track their movements with as much precision as their phones would give us over the course of 3 days. And so that was really cool because here again, for the first time, we're getting this information over the course of an entire small town of how people move, how they interact, how that changes by time of day and by day of week. And so this really gave us some interesting insights into human mobility. So for this national part, we had upwards of about 40,000 participants. For the Hazelmere outbreak, we had about 500. So this really gave us a lot of interesting insights into these movement patterns of the UK. Some of the things that we learned, the top in support of that hypothesis that I mentioned earlier is that it actually does seem like kids travel substantially shorter distances than adults. So basically the way to read these figures is that distance is along the horizontal axis, 1 minus the cumulative density of observation of movements at that distance is along the top. So the lower down one of these curves sits, the lower the average distance that's traveled. And so basically kids are traveling the least, young adults are traveling the most. This all roughly aligns with intuition. Same with rural versus urban travel. So people who are living in rural areas need to travel further. Everything that they need is just further spread out. And so we see that manifested in these data as well. With the contact survey, we saw quite a lot of age structure and interactions. So along the top, we see that same tri-diagonal matrix across all contacts. But one of the things we tried to do with this study was to stratify by the venue at which those contacts occurred, because then that allows us to think about different types of interventions, like work closures or school closures or different sorts of things that you might imagine. And so we see that the age structure of contacts at work is, as you might imagine, vastly different than the sorts of age contacts that you have in the population as a whole. And so this begins to allow us to make more precise models about how different interventions might affect the spread of disease. And then last, here's some of the data from the Hazelmere study. So on the top right is a network where each line represents 1/4 of one day where two people were in contact with one another. And the size of the disk represents the number of contacts that a person has. And so you see there's a ton of heterogeneity again in the number of contacts and in the frequency of contacts between people. And in the bottom right, we can actually see people, these dots, starting to move around town. So this is basically some of the trails. This was included in that documentary. And this is essentially people waking up. You can start to see people getting in their cars, driving around. It's pretty remarkable. And so based off of this interpersonal contact data, you can start to ask all sorts of questions about optimal vaccination, targeted vaccination, and really just the frequency with which people come into contact with one another. So I think there's a ton of potential with data streams like this. People have been continuing to collect data like this over the course of the pandemic to try to understand how these behaviors change in a non-pandemic setting versus a real epidemic setting. That's not work that I've been immediately involved in, but I'd highly recommend looking into it if this is an area that you're interested in. So transitioning now, as Dan mentioned, this is now transitioning from my time during my PhD to my postdoc. I went to the Harvard School of Public Health to, again, try to take a step towards more implementation-based work. And really specifically, I wanted to study antibiotic resistance. Unfortunately, I don't think I'll have time today to talk about the antibiotic resistance work that we did. And that's in part because very quickly after I got there, about a year in, the COVID-19 pandemic hit. And so, so we started doing a lot of work on COVID and trying to use some of these modeling paradigms to better understand that pandemic as well. So the first thing that we wanted to try to understand was what the COVID-19 long game is. And to answer that, we had to do a lot of sort of backfilling of our information about coronaviruses in general. Prior to this, I knew a fair amount about flu. And I think a lot of our field who does respiratory infections knew about flu, and we expected to some extent that the next major pandemic would be a flu pandemic. Comparatively, there's a lot less research about coronaviruses, and specifically about pandemic coronaviruses, because we haven't seen a major coronavirus pandemic like we've seen major flu pandemics in recent history. So we needed to take a look at how existing coronaviruses behave before we could really try to get a sense for what the long-term game would look like for SARS-CoV-2. So here's that mechanistic model that I brought up on the first slide. This is really just trying to capture the spread of the two human beta coronaviruses, which are the two coronaviruses that are most closely related to SARS-CoV-2. What we have here is really just what we call a two-strain SEIR model. So we're capturing people who are susceptible, then you can become exposed to infection. Somebody who's been exposed then becomes infectious, can infect other people, and then they recover from infection. And then we also accounted for the potential for waning immunity. And so using this model and using historical data on the transmission of these beta coronaviruses, we just fit the data to the model to try to understand sort of what are the key elements of the transmission of these coronaviruses. So one of the things, there are a couple of things that we could learn from this model. One is that there seems to be substantial cross-immunity between the strains. And if you spend enough time just looking at this time series, you can kind of see this, where in a given year, when OC43 transmission is really high, HKU1 transmission is relatively low. And they sort of trade off in this biannual pattern. There are two different ways that could come about. One is that each of them just has rapidly waning immunity, and they just happen to be off cycle. Or there's substantial cross-immunity. We weren't able to perfectly distinguish between these things, but according to this model, the most likely scenario is that there was both short-term immunity on the order of 1 year, but then also substantial cross-immunity between the strains. And there's also quite a bit of seasonal forcing. And again, that's not terribly surprising based off of this, because we get annual epidemics of coronaviruses really between late December and early January, every single year. And the only way to get that out of the model is to have substantial seasonal variation in the force of transmission. Now, that doesn't mean that it's necessarily linked with the weather patterns. Seasonality can be a much broader concept where it could be related to human behavior, but something is happening such that there's an increase in the transmissibility of these viruses, either inherently or through human behavior, that causes them to surge at this time of year. So we built that into a model for these beta coronaviruses and then layered on SARS-CoV-2 on top, and asked a couple of these if-then statements to try to ask sort of what's the long game for COVID-19 going to look like. So if COVID-19 basically has the same transmission dynamics as the other beta coronaviruses, we expect basically a major pandemic surge and then annual outbreaks thereafter. But there are a couple other scenarios that we could explore. So with SARS-CoV-1, there was some evidence that immunity lasted longer than it did for the other human coronaviruses. So we explored different scenarios where immunity lasted longer, even where immunity was permanent and the cross immunity wiped out the other coronaviruses. We don't think this is what happened there, but I think there's actually an interesting story here with flu, because there's been so much suppression of the transmission of flu with non-pharmaceutical interventions that there was at least one influenza B strain that we really haven't seen much of at all. And so something like this may have happened with that. And then last, I think this is actually the most likely scenario where there's a bit of cross immunity between the different variants. And we sort of see this co-circulation of all three beta coronaviruses over time with sort of multiple peaks during the pandemic. But one of the other things we can ask, this is sort of the uninhibited spread scenario. But then we can ask, what happens if we impose policies? So here we looked at how long it would take to build up population immunity if we did physical distancing to the extent that we weren't going to overwhelm our critical care capacity. So the solid horizontal line along the top is basically the critical care capacity in the United States, the number of beds per 1,000 people. And the blue bars are where we estimated, according to the model, we would need to have this intermittent physical distancing to avoid overwhelming the healthcare system. And so this was sort of the big, this was the one that really got picked up by the media when everybody, it was a couple months into the pandemic and they were like, scientists say the pandemic is going to last 2 to 3 years, and this is where it was coming from. There was a lot that we didn't anticipate here, though. We didn't look at the emergence of variants. We had no idea that vaccines were going to come available when they did. But I think a lot of those things, in a way, according to this model, kind of like canceled each other out as variants emerged, as vaccines came about, and made it so that this actually ended up being a relatively accurate prediction almost in spite of ourselves. As the pandemic went on, we were also interested in sort of drilling down into more geographically focused questions. And of course, as the pandemic was really beginning to spread in the spring of 2020, there were a lot of questions about what was driving disparities in COVID-19 outcomes. So to give some context here, here's a graph showing hospitalizations and deaths across New York City boroughs. And anytime I see geographic variation in disease burden, I often think of socioeconomic and demographic variation in disease burden as well, because those often track very closely together. But one of the questions is this variation where we see essentially half the hospitalization rate in Manhattan, as in Queens and the Bronx, is that due to poorer outcomes given infection, or is that actually due to differences in the rate of transmission? That's an important question because that suggests two very different ways of intervening depending on what the answer is. So if the rate of infection is the same across populations, but there's much worse outcomes in some parts of the city than others, then there's really a question of access to care, thinking about how comorbidities interplay with outcomes from disease. But if there's a lot more transmission in these communities, then we can actually think about reducing the spread of disease as a way of trying to even out some of these huge inequities in COVID-19. So we had access to some interesting data. So this was early on in the pandemic, and there was not a lot of routine testing going on at the time. But the one population that was getting tested frequently was women who were admitted to hospital for labor and delivery. So everyone, all of those women were getting tested. And so that gave us the closest thing we had at the time to an unbiased sample of who was or wasn't infected with COVID-19. And so building off of some work that Dan was also involved in estimating the prevalence of disease, given imperfect testing, biases in the tests, different sensitivities and specificities, we used that to estimate the prevalence of infection across the New York City boroughs. And we saw that actually these differences in prevalence mapped pretty closely to the differences in hospitalizations and deaths as well. Here's that same information in a map, where again, we see much lower rates of infection in Manhattan than in the Bronx and the Queens, sorry. And then we took one last step with this, trying to understand sort of what might be driving this variation in transmission. So we were working with some folks at Harvard who are also doing mobility studies. So they were working with Facebook Data for Good. And with that information, they were able to see, at least at an aggregate scale, how many people were moving between boroughs at different times of day. And what I'm showing on the right here is the reduction in commuting style movements between boroughs from pre-pandemic to the pandemic. It's on a reverse scale. So basically places that are darker on the bottom, on the right map, are places where people couldn't stay home from work, where you have people leaving the borough in the evening, returning to the borough in the evening. And so essentially that's a proxy for how many people were in essential jobs. And again, that matched up remarkably closely with both the differences in infection and the differences in outcomes. So we tried to use this piece to really advocate for better protections for people who were working jobs that they couldn't stay home from, because we really think that that was one of the main drivers of transmission and especially inequitable spread of COVID-19 in New York City, but really everywhere. One last thing here before I get on to future work is sort of at the smallest scale, but thinking about SARS-CoV-2 variants and how they differ in transmissibility. This was a really interesting study. So prior to this, I hadn't done a lot of work in within-host modeling, but we had been collaborating with the NBA and their occupational health program in order to try to suppress outbreaks. It was essentially testing all of their players and staff every day. And they were doing that with quantitative PCR tests. And so that gave us a sense of what a person's viral load when they got infected was. And we could look at that over time. We had some colleagues at Yale who were doing sequencing to understand which variants were in play. And we also had information about the vaccination status of different people in this cohort. So what that allowed us to do was to essentially fit a model. And I'm using the model in a fairly loose term here. All it is really a piecewise linear regression. Where since these viral loads are measured on a logarithmic scale, that captures essentially a period of exponential growth in virus and then a period of exponential decay as the virus is getting cleared. And we can do that across variants, we can do that across vaccination statuses. And that allows us to get a sense of maybe why different variants differ in their infectiousness, or why vaccinated versus unvaccinated people differ in their infectiousness. One of the interesting things we found here is that there actually isn't a lot of difference in the amount of virus that is produced in the body across variants. And that was really surprising because we expected there to be a strong correlation between infectiousness and the amount of virus that was produced. But really what this points towards is that there's probably something structural about changes in the virus that make the virus more transmissible on a sort of per viral particle basis for Delta and Omicron, for example, relative to previous variants, whereas the amount of virus that's produced is basically the same. But we did see faster clearance in vaccinated people. And so that might be partly why people who are vaccinated are not as contagious, because they're just not infectious for as long of time. One of the things we did with this was to incorporate it into essentially an online calculator where, given some parameters of the viral concentrations depicted on the left and some test characteristics, you could essentially say, if we have a gathering of this many people with this baseline prevalence of disease, what's the likelihood of X number of people showing up to the event while infectious? And how many of those people will we successfully screen out if we use a rapid test one day before or a PCR test a few days before, to try to get a better sense of what sorts of tests we should be using and how soon before an event or before a flight or before whatever you might imagine to screen as many people as possible. So taking a quick step back, some of the themes that I've been really interested in are the interactions between pathogens, pathogen variants, and also different pathogens, the impact of human behavior on pathogen spread, and then how geographic and demographic variation affects transmission. So really looking again at these three different scales of disease spread, all aiming towards this question of how we can combine an ecological understanding of infectious disease with technological advances to limit the spread of infectious disease. So with that in mind, I'd like to take a few moments to talk about some of the future work that I'd like to do, and then maybe we can open it up to some discussion. So first, I'd like to take some of this work on within-host dynamics and try to make it a little bit more rigorous and specific. So one of the things that I've been thinking a lot about is that a lot of our statistics are really good at estimating means. But in a lot of infectious disease settings, it's not really the means that matter most. It's probably the extreme viral trajectories that are most important for spread. So what I'm depicting here are our posterior estimates of peak viral load on an individual level for people who are infected with alpha versus people who are infected with delta. And as I said before, we didn't detect much difference between the viral trajectories, but if you actually look at the distributions, they are quite different, where the alpha distribution sort of has most of its mass towards its center, whereas the delta is almost bimodal. And so you have a higher concentration of people at the low end of the distribution, and then a higher concentration of people balancing that at the top end of the distribution. So if it's the people with the highest viral load, say above a log copies per mil of 9, who are most responsible for spreading disease, well, all of a sudden that might explain pretty well why delta is more infectious, because there are a lot more people infected with delta who are at that tail of the distribution than there are for alpha. Okay, well, how do we design experiments to understand not just what the mean is, but what the tails of these distributions look like? Well, one idea is that if you have a fixed number of tests, you have to decide how to allocate them within individuals and between individuals. So one option is to do very intense sampling to get a very good information about the viral dynamics within a single person. And so you test a single person every day or as frequently as you can. But if you do that, you might risk missing these other two infections that are very long or very tall. So you might want to distribute your sampling more broadly, but that gives you less information about what's happening at the within host scale. So there's some trade-off here that I don't fully understand what it is, but I'd like to do some work to understand what this trade-off is between intense sampling versus broad sampling, to do inference not just on the mean, but on the tails of this distribution that we expect to be most influential to transmission. I think that this also will hopefully lead into some broader principles about adaptive experimental design. So this is an area where there's been a lot of research so far, but one of the things that you could envision doing is have everyone who's involved in this study to have an app that basically tells them when to get tested. And you can essentially be doing the statistical inference on these trajectories on the fly. And depending on where you have the least amount of information, you might be able to shift some of your sampling towards more intense sampling when you need it, or more broad sampling when you need it, so that you can sort of maximize the amount of information you get out of these experiments. A second area of work, expanding now a little bit, has more to do with human behavior and thinking about how population structure impacts the transmission and evolution of pathogens. So again, this is the network that we came up with from that Hazelmere study with the BBC. There are a lot of different ways that we can start thinking about interpersonal contacts and how they impact both the spread and evolution of disease. One thing is that people with a lot of contacts naturally play an outsized role in disease transmission and evolution, but in any given study, we might be missing a number of people. And if we miss somebody who has a lot of contacts, then our estimates of how disease transmission is going to look in that population are going to be hugely biased. So when we're missing data, it's going to be especially sensitive to errors of that type. So one of the questions is, how do we build algorithms for network reconstruction that are mindful of this sort of very major error that we could make? One of the other questions is, how does evolution happen on a network like this? So there's been some work in evolutionary game theory that suggests that certain types of networks that sort of look like stars, which arise all the time in epidemiology, actually enhance the probability of success of a pathogen that is slightly more fit than its neighbors. Because essentially, if there's a pathogen that emerges at the center of this network, in this particular network, it essentially has 5 different trials in which it can succeed. And if it succeeds in any one of those arms, it can propagate back to the center and then propagate through the entire network. And so the network structure can really affect the evolutionary dynamics of pathogens and populations, and I'd be interested in understanding that question much better. And in terms of interventions, one place that I could see a lot of this heading is thinking about how we can use things like these mobile technologies that are collecting the sorts of data that capture human interactions to improve our vaccination strategies. There was an explosion in digital contact tracing technologies during the COVID-19 pandemic. And I think that their reception and their value was mixed. It was probably not as big as it could have been. And I'd like to try to understand why that is. And I'd also like to see if we can use those kinds of technologies, not just for contact tracing, but even to simulate vaccination strategies across a population, to do so in a decentralized and privatized way, but in something that can basically tell a policymaker, this is the demographic of individuals who's most important to vaccinate if you want to interrupt spread, without ever compromising the actual individual behavior of any single person in the population. A lot of the structure is already there with the digital contact tracing technologies. We just need to think about it from a vaccination paradigm to figure out how to do that. And then the last thing here is thinking about how we can integrate pathogen genomic surveillance with transmission models to control respiratory viruses. So this circles all the way back to that first study that I introduced on pandemic flu. But now we have a lot of really interesting opportunities in the aftermath of the COVID-19 pandemic, because the pandemic has perturbed the circulation of a lot of different pathogens. So here, the RSV, the regular circulation of RSV, which usually happens in the winter, was shifted by about 6 months. So it was circulating in the summer of 2020, which we don't normally see. The flu was almost completely suppressed. And then for strep pneumo, which is a bacterial disease that affects a lot of different people, but it's really a major cause of things like ear infections in young kids. And so therefore drives a lot of antibiotic prescribing and antibiotic resistance. We saw a huge decline in disease. So the dashed blue line is the usual pattern of strep pneumo. The solid line is the pattern in 2020. But actually carriage stayed the same. So that suggests that a lot of strep pneumo disease is actually probably due to primary viral infection. And then there's the secondary bacterial infection that comes along the top, causing disease. So how do we make sense of this? Well, there are a couple of questions that this raises. So first, from a basic epidemiological point of view, how do respiratory pathogens suppress and promote each other's transmission? Then we can ask about how should we distribute our surveillance to get a better understanding of which of these pathogens is circulating where. And all of that is aimed towards trying to understand, okay, so we have new vaccine platforms that we might be able to develop vaccines against these pathogens. Depending on what our strategies are, which pathogens should we vaccinate against to achieve some specific outcomes? So in this case, if we wanted to reduce disease caused by strep pneumo, we might be actually better off to produce a good vaccine against flu or RSV. Maybe that would go a longer way towards reducing rates of strep pneumo than developing a new strep pneumo vaccine after we already have one that's valent against 13 different strep pneumo varieties. So really, I would like to use these questions to sort of optimize surveillance and then to start asking policy questions about what sorts of technologies do we need to develop next to gain the best control of infectious diseases. In the long term, I'd like to take some of these ideas and sort of broaden them towards crisis prevention and crisis resilience more broadly. So thinking about how computer technology can interface with preparedness, response, and resilience for crises more broadly, including pandemics. I'm interested in the question of compound crises as well. So during the pandemic, I couldn't help but think about all of the other things that happened over the top of it. We have the situation in Ukraine right now, for example, where Ukraine is one of the countries in Europe that has the highest tuberculosis rates of anywhere in Europe. And so people who are crowding together in response to the war, that could promote the spread of tuberculosis as well and cause these compound crises. How do we use computational tools to help people mitigate the effect of crises as they occur on top of each other? And then how can we use technology more generally to empower good individual decisions and good social decisions while maintaining privacy, which is, I think, an incredibly important thing, not just for an ethical perspective, which it is, but also just for the uptake of these technologies in the first place. I think if they compromise our privacy, they're a lot less likely to take hold. So that's a broad overview of the things I've done and the things I'm interested in. There have been far too many people involved in this work than I can possibly acknowledge on a single slide, but I do want to mention the group for my PhD working with Julia Gog, the group for my postdoc working with Jonas Grad, and they've been just unbelievably supportive and just great fun to work with. So thanks a ton to them. Thanks very much to all of you. Be very happy to take some questions and discussion.
Yeah. The S thing, was that strep?
Mm-hmm.
Okay.
Yeah.
And then what your point was, it came with a virus, so it came in using with COVID now?
The strep pneumo?
Yeah.
And can I request that you repeat the question for the folks on Zoom?
Yes, great. So, so this was asking about strep pneumo or Streptococcus pneumonia, which is a bacterial infection, and asking whether it sort of emerged with COVID or if it's been circulating previous to that.
Well, you mentioned that the plots suggest it came with the bacterial host, viral host.
Right. Yeah. So, so my sense, and that's just one hypothesis here, sort of one reading of these data. But so you can imagine sort of two different hypotheses. So strep pneumo is a bacterial pathogen that also generally causes most infection in the winter months, as most respiratory infections do. But what we see with this particular study is that while invasive disease from strep pneumo declined, we still, if you swabbed somebody and cultured what was in their nose, you still see the same amount of strep pneumo that was there previously. And so what that suggests is, unlike RSV and flu, where masking and distancing really reduced the amount of virus that was just spreading in the population. Here, masking and distancing didn't really do much at all to how much strep pneuma there was out in the world, but it did reduce what strep pneuma was doing. And so the only way that I can think of explaining that is that that strep pneuma is causing disease because it's sort of opportunistic. And so by reducing the rates of these other illnesses, it may have helped prevent strep pneuma from doing its opportunistic thing. That's just the best way that I can make sense of these data, but there's a lot more studies that need to be done.
So that it's not actually co-occurring with the COVID virus, but
Right.
maybe previous other virus.
Exactly, right.
And then also for that famous plot that showed things after January 2022, how far out did the simulation go? And can we read the tea leaves of, the future simulation from that one?
Yeah, so to some extent, so this simulation went out to basically 2023, and we stopped it after that point because that was when, if you assume permanent immunity, you reach a level of herd immunity. So essentially enough people in the population who are immune that you can't have sustained transmission from them. Trouble is that was assuming a reproduction number of about 2.5. We now have Omicron, which has blown that out of the water. But we also didn't account for vaccination. And in these plots, we didn't account for the fact that immunity would probably be waning and we would get these recurrent epidemics after that. So you could very much use the same model to understand what's happening now, but it would need to have quite a few more bells and whistles to account for a lot of that. Much of which some people in the audience here have also done some work on taking a look at the transmission of COVID-19 in the context of vaccination. So,
Stephen, if your audio is on, Leisha has a question.
Great. I believe the audio is on, so fire away. I'll let you know if I can't hear you.
Okay, Stephen, can you hear me? It's Leisha Palin.
Hello.
Great. Hi. Okay, wonderful talk. Thank you so much. I'm also interested in different forms of crises that cause human displacement. And that's, I think, really the question is when you have other hazards that intersect during the pandemic that cause human displacement and therefore congregation in public spaces that they weren't expecting to do, what does the spread look like? So I just want to make sure I understood your interest a little bit. Are you suggesting that you could model to anticipate what that spread might be if unexpected convergence happens? Or are you thinking it's more of a post hoc analysis to then understand how, a new locus of a source of spread or something like that? What is your interest in the modeling and of those compounded crises?
Yeah, thank you. So for these kinds of crises, I think I'm both interested in the post hoc modeling. I think there are plenty of examples where we can just gain a deeper understanding of how contagion has occurred amidst the backdrop of other sorts of crises. And I think there's a lot to do to just get a deeper understanding of that through modeling. But I think my main interest in the direction that I'd like to head is to start thinking about what sorts of resources do we want to have available for people who might be in this kind of setting. So I'd actually like to think about, I'm extremely interested in computers and computational technology, but I'm also interested in what people did before computers came around, because I think that can sometimes tell us a lot about how human behavior basically point towards the needs that people have that can be addressed by computers that people were sort of addressing in other ways first. So thinking about, and I'm not even sure how to begin to do this, but this is something I would love to think with people who are a lot more involved in crisis science and social studies and such, do know a lot more about, is just how have people tried to mitigate the spread of disease in these settings? And how does it differ from the ways that people treat contagion when there isn't a concurrent crisis going on? So do you just forget about the fact that there's a contagion? Do you try to do less, or are you more attuned to the fact that there's a contagion? And if so, what do you do about it? And then how can we develop, I'm not even sure exactly what it would look like, but thinking about what sorts of types of communication people need with one another, what sorts of resources do you need, what sorts of testing do you need? As we're sending aids to different countries, should they include rapid tests? Should they include what? I'm not sure. But I think just sort of thinking broadly about that question of like, how should we manage the spread of infectious disease in these situations is kind of what I'm interested in. I don't know if I've completely dodged your question, but
no, it's great. I mean, there's just so much here to think about. There isn't
right.
a clear answer, but yeah, no, I really appreciate your thinking about these intersections. So thanks a lot. I look forward to speaking more tomorrow.
Yeah, likewise. Thanks.
Yeah, thanks for the great talk. I was curious if you could talk about, so I am roughly familiar with like meta population models.
Yeah.
I was curious, I really appreciated what you were talking about as far as those waves spreading and how you were using almost like a radial basis function to with the cities. And so I was curious if you could talk about how those two approaches kind of inform one another.
Yeah, thanks. So and the question was about meta-population models, which are models that essentially think about a population as a population of subpopulations, where within the subpopulations, you have essentially well-mixed behavior, and then there's some interaction between those populations that allows the spread of infection or what have you. And then that there's also this sense of almost a radial basis function, where you have some kernel that specifies the probability of transmission or the force of transmission between metapopulations. And sort of how to, like, what is the overlap between metapopulation modeling and the sort of more, what I understand to be sort of like continuous space modeling, where you have sort of the spread of disease in space. So in my mind, there's a ton of overlap, and the approach that one takes really just depends on the sorts of question that you're trying to ask, the type of data that you have, and the level of computational resources you have to throw at it. So there's actually been a lot of success in the more continuous space type models in ecology, especially insect ecology, where we've seen the spread of invasive species, for example, or even the spread of diseases in wild populations, like the spread of rabies in foxes, for example. They've been using a lot of these kinds of continuous space models. Those are great, but the mathematics of them can be very complex, which shouldn't be a deterrent necessarily, but they can also be, you can run into some interesting difficulties where you have disease in places where there are no people, or you have like hundreds of thousands of individuals who are infected that then cause a resurgence of infection somewhere. So it's generally known as the Addofox problem, where you have one Addofox who's infected across the entire country, but is able to seed a new epidemic. So you have to be very careful when you're formulating those kinds of models. And I think one of the reasons that people tend to transition towards metapopulation models is that it avoids some of those complexities, because you still have discrete units, but you can still incorporate some amount of this spatial structure within the model. So it sort of gives you the best of both worlds, or the worst of none, depending on what your perspective is. But there's a lot of crosstalk between the two for sure.
I'm just curious about the heterogeneity of the types of data sets that you deal with to do this type of work. You have organizations that you turn to that have data sets you always rely on. We always assemble data sets on your own. Is that, how much that is your work primarily doing your data cleaning to get to the point of making these kinds of graphs and inferences, or you have like organizations that report data that is exactly.
Yeah, thanks. So the question was about data sources and what different types of data we work with, what degree of cleaning is needed, and are there organizations that we go to routinely to get data? Sort of what is the state of epidemiological data right now? It is poor but getting better, and so there are. I gotta be careful what I say. So there are traditional data streams, and those include places like the CDC that do routine data collection that can be very good for some things. There are a lot of non-traditional data sources. So one of the data streams that I have been using a lot, not so much for this work, but a lot for the antibiotic prescribing work, is medical insurance claims records. So every time you visit a doctor, you generate an insurance claim that's associated with a diagnosis. And since insurance companies need to make money, they take very good records of exactly what's going on. And so there are all sorts of issues with those kinds of data too, but they can give you very good longitudinal individual level data of disease in a population and in individuals over time. So I think that's one really interesting source of data. A lot of data right now in epidemiology is sort of passively collected. It's done for the sake of suppressing epidemics, but then we sort of get our hands on it and do the best we can with it. And I think that's one of the things that I'd really like to try to shift. I would love to do some of my own perspective data collection, sort of like we did with the BBC study, but I think that more generally, I think it's, let me maybe put it this way. There's been a lot of conversation lately about the link between climate and weather modeling and epidemiology. And I think the thing that really revolutionized climate modeling certainly was the math and the computational power, but a lot of it was the data. The fact that you have beacons all over the place that are constantly collecting data and spitting it out, putting it in a unified format that people can gather and then develop their models off of. And so I don't expect that we'll ever be quite at the point where weather modeling is in terms of data, because people are people, and we, you know, raindrops don't have privacy issues. There is a lot to be done there. I think that there's this sense that we have to do things the way we've always been doing them, but I do think there's a lot of latitude for doing randomized surveillance and for thinking about using these kinds of tests. I think especially with the rise of telemedicine, with the rise of rapid at-home testing, we can distribute these things in a way that we weren't able to before. And I think that that might allow us to take one step closer to actually gathering data rather than just analyzing it. Thanks.
Okay, we're right at time. Maybe one more question and then we'll call it for the day.
So I have a general principle about the short-term prediction.
Yeah.
So what do you think what it takes to have a model to have an accurate short-term or first fast time scale prediction?
Yeah, so the question is, for short-term predictions, just what does it take to make a good model? Is that right?
Yeah.
Yeah, so in my mind, the short answer is that it actually takes many models. So the best models that we have for short-term prediction are usually based off of an ensemble. And this again comes from climate modeling. A lot of the paradigm is built there, where you have different teams all over the world who are generating their own models, some of which are based off of machine learning, some of which are mechanistic. And it turns out that the weighted average of those models almost always performs better than any one model on its own, because they sort of account for each other's inefficiencies and different sorts of behavior that could never arise with one model do in another. And so I think that's a really interesting thing, because you know, certainly what makes a good model is good data, model structure that's flexible enough to account for the differences in the data as it comes in. But I do think, I mean, I don't mean this as tongue-in-cheek at all. I really do think that we need to start thinking about not just building models, but building model ensembles. We should be, like when we're trying to answer these questions, we should be answering the same question with a machine learning model and with a mechanistic model, with a different type of mechanistic model, and trying to find a consensus between all of them, because experience suggests that that will actually be the best alternative. So, so I think, you know, we need people who are interested in, answering the same problem with all sorts of different techniques, because it really does seem like the combination of those things gives you much more robust, much more accurate estimates than any one on its own. Thanks.
Stephen, thank you so much for your time. I just posted your email address in the chat for folks on Zoom if they have more questions.
Yeah, please reach out anytime. Thanks everyone on Zoom.
Thank you.